Burton, President and CEO of the American Kidney Fund, and I'm delighted to welcome you to today's briefing, COVID-19, Health Disparities and the Social Determinants of Health. We're honored to bring you a star lineup of speakers who will keep you informed and we hope inspired over the next hour. And I'm also pleased to note that yesterday was the beginning of National Hispanic Heritage Month, so our topic is very timely. The American Kidney Fund fights kidney disease on all fronts as the nation's leading nonprofit working on behalf of 37 million Americans with kidney disease and millions more who are at risk. An integral part of our mission is to fight health disparities, which have really been brought into sharp focus by the COVID-19 pandemic and its disproportionate adverse impact on communities of color. Here at AKF, we are acutely aware that race is a significant risk factor for advanced kidney disease. Even though Black people comprise only 13% of the nation's population, they are over a third of people with kidney failure. Hispanic people are more than 1.5 times more likely than non-Hispanics to develop kidney failure, and Native Americans are also at higher risk. Unfortunately, the disparities that we see in kidney disease are mirrored in what we now see happening in COVID-19. The impact of COVID-19 on minority populations and ESRD patients is not unexpected, given the high rates of hypertension and diabetes in our communities, as well as heart disease and other multiple chronic conditions that make a person more vulnerable to COVID-19 complications, hospitalizations, and sadly, even death. Recent data from the Centers for Medicare and Medicaid confirm the racial and ethnic disparities among Medicare beneficiaries and the serious impact of COVID-19 on people with ESRD. Black people have the highest rates of infection and hospitalization among racial ethnic groups and have been hospitalized 4 times more than white people. Hispanic people have been hospitalized 1.5 times more. Medicare beneficiaries with ESRD have the highest rates of hospitalization, 8 times higher than the general Medicare population. COVID-19 has really put a spotlight on the social determinants of health, which the World Health Organization defines as the conditions in which people are born, grow, live, work, and age. There is ample evidence that these factors have a far greater impact on health status than even the medical care that people receive. Therefore, we really cannot address health disparities without also addressing social determinants of health. Our briefing today will explore what social determinants are, the impact they have on minority populations and health disparities, as well as some possible pathways forward. While improving social determinants will require a broad social change, there are some things that we can begin now. Our speakers today are Congresswoman Nanette Diaz Barragán from California, Dr. Eduardo Sanchez, the Medical Director for Prevention at the American Heart Association, Dr. Oliver Brooks, Immediate Past President of the National Medical Association, and the Medical Director of Watts Healthcare in Los Angeles. Ms. Cindy Benavidez, CEO of the League of United Latin American Citizens, also known as LULAC, and Mr. Patrick G., a kidney transplant recipient and AKF ambassador. We are also thrilled to have former Congresswoman Donna Christensen, who is a member of the AKF Board of Trustees, here to moderate the panel. And now I'm going to check to see Congresswoman Barragán is joining us.
I'm here.
She may be delayed by a vote. Oh, great, Congresswoman. We're so delighted to have you. Thank you for joining us. We knew you had important business in the House. Congresswoman Barragán was elected to the U.S. House of Representatives in November 2016, the first Latina ever to represent California's 44th Congressional District, which includes South Los Angeles and Los Angeles Harbor region. As the youngest of 11 children raised by immigrant parents from Mexico, the Congresswoman knows firsthand about the challenges that many low-income families, minority families face. She is the second vice chair of the Congressional Hispanic Caucus and a member of the Progressive Caucus. She serves on the House committees on Homeland Security as well as Energy and Commerce. In 2019, she became only the second Latina ever to serve on Energy and Commerce. AKF is very proud to support her legislation, HR 6561, Improving Social Determinants of Health Act of 2020. And we look forward to hearing more about it. Congressman Barragán.
Well, thank you so much. Thank you for the opportunity to speak with you today about the need to address social determinants of health, especially during this current public health crisis. I want to thank AKF for organizing this important briefing. COVID-19 is just the latest disease to infect and kill communities of color at higher rates than people in the rest of the population. We've seen firsthand what the crisis is doing to our communities, especially those that are in low-income areas and don't have access to the services they need. That's why we must examine the social, economic, and environmental factors that drive this inequality, such as poor housing conditions, food insecurity, fewer transportation options, and lack of educational opportunities, and we have to address these issues. Now consider a person with diabetes, a disease African Americans and Latinos are 70% more likely to be diagnosed with than their white counterparts. This person is trying to manage their condition through proper diet. However, that becomes almost impossible if they live in a food desert with fewer grocery stores and opportunities to buy fresh, healthy food. I learned this lesson firsthand with my mom, who's an immigrant, only had a third grade education in Mexico, had diabetes, was in the hospital, had to come and live with me after an operation that she had. Now, I was incredibly fortunate to be able to have meals prepared for her, tailored to her health condition, and they were delivered to her at my home. Because she had access to proper nutrition, she was actually able to temporarily get off all her diabetes medication, and this would not have been possible if I didn't have the means. And for most constituents I represent, this is sadly not an option. So with diabetes being one of the leading causes of kidney failure, many eventually have to be placed on dialysis. However, they can have difficulty accessing their treatment because they don't have easily accessible transportation options. So it's access to food, things like access to transportation. And scenarios like these are also some of the reasons why we see a lack of access to care. Patients need to be able to see a healthcare professional early to prevent the diabetes, to prevent the issues, not after they have it. It's better to know that you're pre-diabetes and are told the things that you need to do to try to help prevent it from coming on and to actually manage their conditions. And so all of these factors are just some of the reasons why we have high levels of health disparities between underserved communities and more affluent areas. So we need to address these factors in order to reduce inequality and solve this problem. Now, I believe the first step is a bill I introduced, Improving the Social Determinants of Health Act. This bill will provide funds to the CDC, the Centers for Disease Control, to establish a program focused specifically on the social factors that influence health disparities. It would also establish a grant program for state, local, territorial, and tribal health agencies to tackle this issue, as well as award grants to nonprofit organizations and institutions of higher education to conduct research on social determinants of health best practices. So now is the time for us to address these issues, which will help reduce the unacceptable health disparities that hurt our communities. And I'm thankful for the support of the 230 national and local organizations, including AKF, that have supported this effort. And hopefully we can make meaningful progress in Congress to address the social determinants of health in the months ahead, especially as we deal with COVID, and we need to find opportunities to close these gaps. So thank you again for the opportunity to participate in this important conversation today. Before I turn it over, I also want to note that it's great to see Dr. Brooks, who is an esteemed medical professional in my district, as the medical director and past chief of pediatric and adolescent medicine at Watts Healthcare Corporation in Los Angeles. Dr. Brooks has spent his life caring for those in underserved communities and will help be able to provide a unique perspective during today's briefing. So to AKF, Dr. Brooks, and all of the panelists today, I look forward to continuing to partner with you in the fight to improve social determinants of health and reduce disparities. And with that, thank you so much for having me.
Thank you so much, Congresswoman, for joining us and for all of the work that you are doing to advance this extremely important cause. For our participants, I want you to know that after the panel has completed, we hope to be able to take questions from you. So if you have a question that you want to raise, please write the question in your chat box. And now I want to introduce our moderator for this afternoon. Former Congresswoman and Dr. Donna Christensen won election to the U.S. House of Representatives in 1996, the first woman to represent the U.S. Virgin Islands, and she served until 2015. During her tenure, Dr. Christensen, the first female medical doctor to serve in Congress, focused on improving living conditions and economic opportunities on the islands. During her tenure in Congress, Dr. Christensen served on numerous committees, breaking ground as the first delegate to serve on several of them. She chaired the Congressional Black Caucus Brain Trust for 16 years. In that capacity, as well as in her seat on the Energy and Commerce Committee, she was intimately involved in the creation of the Affordable Care Act, especially the health equity provisions. We're delighted that 2 years ago, Dr. Christensen joined the Board of Trustees for the American Kidney Fund. And now, Dr. Christensen, I'll turn this over to you.
Good afternoon, everyone. Good. Good afternoon, everyone, and it's a pleasure to be here to moderate as part of the AKF family this afternoon and to be here with our distinguished panelists. And before I begin, I just want to do a quick snapshot of some of the social determinants of health that have been plaguing our communities for far too long and continue even today. Next slide. Of course, poverty is the root of all of the social determinants, and as you can see here, Blacks, Hispanic Americans, and American Indians are over-concentrated in high poverty areas. Next slide. And yes, even though our unemployment rates have been going down, continuing from the previous administration, you see that African Americans are still having the highest unemployment rate, and some of the jobs that all of us have are not, all of our communities have are not necessarily the best. Next slide. Median household incomes, Hispanics and Blacks are at the lower end of that slide. And though Asians show the highest median household income, there's a great and growing disparity between the high income earners and the low income earners, which is of concern. Next slide. Education is the best pathway out of poverty and also to better health and longevity. And we can see here just from this headline that our children are being shortchanged in their education and hampered in their educational achievement because of that. Next slide. And still, there are low-income communities, communities of color in rural areas that don't have access to healthy foods. Next slide. And live more than the white community in areas that suffer from high pollution in their atmosphere and in their water. Next slide. one of the ways to address some of the health disparities is to have more health providers that speak and look like those that they're taking care of. We're not doing very well. These are active physicians. The light blue at the top is African American, the green, Hispanics or Latinx, and that little blip in between is American Indian. Not doing well at all in terms of active physicians. And next slide. And we're not doing much to correct it either, because here on this slide, these are the graduate cohorts from the last school year from medical school. Green, African Americans, orange, Latinx, and I really can't tell you, I think the 1% is the American Indian. You can't even see it. Next slide. And so this is not just in physicians, it's across the board in the health professions. Next slide. And we find that even today, we're seeing racial bias influencing health care and health outcomes for people of color. Next slide. And beyond just in the office practice and the providing a personal service, there are unfair algorithms that affect you in hospital and with your insurances. So that's just a snapshot of some of the things that create the social determinants of health. And now we're going to really get into the details of it as we begin to hear from our panelists. And our first speaker is Dr. Eduardo Sanchez, the Medical Director for Prevention at the American Heart Association. Dr. Sanchez is going to talk about the biological and non-biological factors that lead to diseases, including kidney disease, and some of the steps that we can take to address them. Dr. Sanchez.
Good afternoon. I hope you can hear me and I hope you can see me. On behalf of the American Heart Association, we are pleased to be partnering with the American Kidney Fund to talk about these really important issues. Let me start with just setting the stage. COVID-19 is still around. Globally, close to 30 million cases and close to 1 million deaths. In the United States, those numbers are about 6.6 million cases and close to 200,000 deaths. As we look at domestically, you can see on a slide that there are 4 states now that have a lot of activity going on: California, Texas, Florida, and New York. I won't go into those numbers. Next slide. In 2018, the causes of death in the United States, top 10 included heart disease, stroke, diabetes, kidney disease. You can see them in that order. If all things stay the same, in 2020, COVID-19 is going to become the number 3 cause of death, and it's going to push those below it down. As we're going to talk about in a moment, these aren't just numbers, these aren't just statistics, these are people's lives, and the disease is affecting people in the United States in not equal ways, in very unequal ways. The mission of the American Heart Association is to be a relentless force for a world of longer, healthier lives. And COVID-19 has absolutely gotten in the way of our mission and the mission of AKF. CDC tells us that the following list are conditions that put people at increased risk of severe COVID-19. And you could see that, and this is not a complete list, but the way I put it, I have chronic kidney disease at the top, and then conditions that are related to and live with and are associated with chronic kidney disease: obesity, serious heart conditions, type 2 diabetes. There's also an accompanying list of conditions that might increase risk, and I've got there cardiovascular disease, hypertension, smoking, and type 1 diabetes. So as you know, in this country, 37 million people with kidney disease. In a minute, I'll talk about the disparity. We know that it exists. 90% are unaware of their disease. Hypertension and diabetes, which are 2 very, very important cardiovascular disease modifiable risk factors, are major causes of chronic kidney disease. There are other risk factors, and I think for me personally, as Chief Medical Officer for Prevention at the American Heart Association, what we can do to modify risk factors is critically important, and early detection is critically important among those who don't even know that they've got literally a couple of ticking time bombs. That would be the 2 kidneys. There is some disparity in chronic kidney disease, and I'm going to let you find these sources and find this data rather than dive into it. But there's also disproportionality and disparity as it relates to high blood pressure, who has it, and to what level it's controlled. In diabetes, disparity, and with obesity in this country. People who have obesity are also represented in disproportional ways. And you can see, I'll delve here for 1 second, African Americans, persons who are African American and persons who are Hispanics have the highest level of obesity, which contributes to type 2 diabetes, which lives with hypertension, and the two together contribute to chronic kidney disease. We also have heard already about the disproportionality of COVID-19, and focusing only on mortality, what I want you to just see is that here with death rates, you can see that Black Americans, Indigenous Americans, Pacific Islander Americans, Latino Americans have higher rates of mortality than white Americans. Put a different way, if you look at it this way, Black Americans 3 times as high a death rate, Indigenous people 3.2 times as high, Pacific Islanders and Latinos about 2.5 times as high a death rate. And as we heard earlier, there are socioeconomic factors that may be contributing to some of this disproportionality. The first 2 are related to some socioeconomic factors that we heard about a moment ago. One is the category of quote unquote essential work. That is work that you can't do from home, you can't do on a computer, you can't do on Zoom, that requires you to be somewhere else outside of your home, often in contact with lots and lots of people. Sometimes in contact with lots and lots of people who may be infected if you are a person who's a frontline worker in healthcare or in public safety. But if you work in supermarkets or you are driving buses, you are in contact with more people. That just raises the likelihood, the possibility, better word, the possibility that you might get infected. And then, as we heard earlier, poverty is a serious challenge in this country to achieving optimal health. But with poverty comes what and how you spend your money as wisely as you can. And sometimes living in small spaces that have lower rents that are affordable means that many families or many generations of families are living together. Those crowded living situations make it difficult to separate and socially distance in this time of COVID. And then I like to talk about the 3 U's, 3 other socioeconomic factors, being uninsured, not having insurance, underinsurance, that is not having the money for copay or deductibles, and then persons who are undocumented, are people who have barriers that, whether perceived or real, delay seeking care because of either economic barriers or fear of some action by ICE. And last slide, there are some things that we can do and think about in the future. 4 things. Adequately resourced public health system overall, federal, state, and local, so we're not dealing with cases in hospitals and then worrying about the likelihood of severe COVID. Health insurance for all. The AHA believes very, very strongly that with health insurance for all, we might mitigate some of the consequences of being an essential worker. Telehealth, telemedicine that's broadly expanded and takes into account the digital divide and makes broadband access available to all. And then lastly, and so glad to hear that there is legislation in this arena, public health and healthcare that includes assessment of patient social needs and adequate funding for social services. So with that, I'll close and hand it back.
Dr. Christensen.
You're muted, Dr. Christensen.
Oh, okay. Sorry. Thank you, Dr. Sanchez. Our next speaker is Dr. Oliver Brooks, the immediate past president, my immediate past president of the National Medical Association and medical director of Watts Healthcare in Los Angeles. Dr. Brooks will discuss the impact of systemic health disparities and social determinants of health on the Black population that he cares for every day in Los Angeles. Dr. Brooks.
Thank you, Dr. Christensen, former Representative Christensen. Good afternoon, members of Congress, other attendees, and panelists. And thank you to LaVarne, Burton, and the American Kidney Fund, the AKF, for organizing this congressional briefing on COVID-19 and the health disparities and social determinants of health. I testified to the House Committee on Energy and Commerce, the Subcommittee on Health, on June 17th on the same issue. That was about exactly 3 months ago. And it is still a major topic and the concerns continue. It is an important, indeed critical topic that needs continued focus as we move through this pandemic and see the US approaching 200,000 deaths, as Dr. Sanchez alluded to. There needs to be no let up in keeping in the forefront of issues of adverse outcomes from COVID-19 in communities of color as daily lives are lost. These are lives that need not be lost. We're talking life and death. The National Medical Association is the collective voice of African American physicians and the leading force for parity and justice in medicine and the elimination of disparities in health. This is not new to the National Medical Association. We have been working for decades to reduce the disparities in health outcomes. National Medical Association is the largest and oldest national organization representing the interests of more than 50,000 African American physicians and the patients we serve. Therefore, the subject matter being discussed is in line with the mission of the NMA. And I would like to thank former Representative Dr. Donna Christensen for her support for the operations of the NMA through the years. And as the formal chair of the CBC Congressional Black Caucus Brain Trust, she has been working tirelessly in this area to reduce disparities. So thank you, Dr. Christensen. CDC data as of September 15th states that African Americans are 18.7% of cases, 21% of deaths from COVID-19, both out of proportion to the representation in the US. We're about 3 times more likely, as stated, to die from COVID-19. Latinos are 3 to 4 times more likely to die. 730 cases per 100,000 versus 230 per the white population for the Latino population. And the CDC has specifically noted, as stated, CKD, type 2 diabetes, obesity, and serious heart disease are high-risk conditions that do lead to adverse outcomes. Asthma and hypertension may be, but as we see, they are there. As stated, African Americans are 70% more likely to have diabetes, 30% more likely to be obese, and 40% more likely to be hypertensive. So there's a direct line there between these underlying conditions and adverse outcomes from COVID-19. And as stated by Ms. Burton, 8 times more likely CKD and renal disease versus other Medicare conditions that you would think would have it, such as being aged or disabled. So CKD is a major risk factor for being hospitalized and therefore dying from COVID-19. So we really see the disproportionate effect of these underlying conditions as it relates to COVID-19. Pandemics do not cause inequities, though. They unmask them. So these inequities didn't come from COVID-19. They're exacerbated by COVID-19. So we must ask why. The 3 real reasons are social determinants of health, racism, and pre-existing or underlying conditions. And there's a weaving, there's a thread that connects all of them. So I want to just touch on racism for just a second. we need to address that. I mean, it's part of this forum now as I bring it up. When you factor out insurance, income, education, Blacks still have poor outcomes. There's an example that came from a study, 2018 study entitled Race and Economic Opportunity in the United States, an Intergenerational Perspective, that found in 99% of neighborhoods in the US, Black boys earn less in adulthood than white boys who grow up in families with comparable income, live on the same block, and went to the same schools. So the only difference between these white boys and these Black boys that grew up to be young men was race. So race is an independent factor for outcomes. But back to the social determinants of health. The disparities are those that we've already discussed. Health insurance, living in neighborhoods with more pollution and less access to healthy food, jobs where we cannot work from home, and even access to capital. Minorities are more likely to live in densely populated areas, live in multi-generation households, and work in essential service industry jobs that make social distancing during the COVID-19 pandemic more difficult. Communities of color also encounter bias in healthcare systems that result in inadequate and lower quality of care. All these are contributing factors that make racial and ethnic minorities more vulnerable during a public health emergency, and all the available data provides this as a fact. 70% of Blacks live in 30 miles of areas determined to have the worst air quality. Think asthma. 22% of African Americans live in food deserts versus 12% of European Americans. Think obesity and diabetes. 19% of Latinos and 11% of Blacks are uninsured versus 8% of whites. Think hypertension. If you don't have insurance, you're not going to a primary care doctor, generally speaking, and you're not getting your blood pressure checked. Blood pressure, hypertension is a silent killer, leading to kidney disease. So what should we do? I mean, we talk about these issues. What do we do? We first understand that they are present and they are important. So we address the underlying conditions. We support universal health care coverage. We're the only nation, as all of you know, in the first world, the developing world, that does not have universal health care coverage. We support funding for small businesses. Small businesses are the economic backbone of this country, and yet only 1% of Black businesses actually have gotten small business loans versus 7% of white businesses. So that economic link needs to be made. We form strategic partnerships such as the AMA and the American Kidney Fund. I appreciate that. We support efforts that increase the number of African American doctors. That was noted. As studies demonstrate that Blacks treated by Blacks have better outcomes. We support HR 6761, the Improving Social Determinants of Health Act of 2020, that addresses many of these issues as delineated by Representative Barragán. I am in her district. We have 22,000 lives here, and I see firsthand how difficult it is to take care of these patients when they live in food deserts, when they don't have transportation, when their insurance goes in and out. So those issues, when they address, will allow me to give better care to my patients. We support passage of the HEROES Act. It addressed a lot of these issues. So that the House stood up. It's not there. And lastly, we shine a light on these issues of disparities in the relationship to social determinants of health, as sunlight is the best disinfectant, right after soap and water and hand sanitizer. Thank you again to American Kidney Fund for hosting this briefing, and I will leave it there.
Dr. Christensen.
I believe I'm unmuted. I don't see my,
You're unmuted now.
yes. And my video should be up.
Your video is fine.
Okay, good. I'm not seeing it. So thank you so much, Dr. Brooks. And now we're going to hear from Cindy Benavidez, the CEO of the League of United Latin American Citizens, better known as LULAC. Ms. Benitez is the first female CEO of LULAC in its 90-year history. And we're going to hear from her how health disparities and the social determinants impact the Latino community. Ms. Benitez?
Good afternoon, buenas tardes, and thank you, former Representative Christensen, for that introduction. Thank you also to the American Kidney Fund and LaVarne Burton for these invitations. As everyone knows, and as LaVarne mentioned, kidney failure is something that does occur in the Hispanic community at 1.5 times more. And in fact, in 2010, there was a 13% of new kidney failure patients were of Latino origin. I also want to thank Representative Barragán for her leadership and for all the work that she is doing to make sure that we are addressing these disparities that are so critical and so important. What we're seeing in the Latino community, and before I jump on, I did want to give a little bit of background about LULAC, the League of United Latin American Citizens. LULAC is the oldest and largest national Latino civil rights organization in the country. We are 91 years young, 91 years strong, and what really sets LULAC apart is that we are a network of volunteers. These are committed individuals who live and work in over 41 states across the US, Puerto Rico, and Washington, D.C. And oftentimes when we see different emerging cases happening, we get the information directly from our members, directly from the community. Many of our members have diverse backgrounds. They range from the ages of 12 years of age, and our oldest member just turned 100 in April. We also have individuals of different economic backgrounds and individuals who work in different fields, from being retirees to teachers to students in high school or college, to being entrepreneurs, to being multimillionaires, to being low-income families. So know that we really do represent the breadth of who our Latino community is in America. As we dive into COVID-19, we certainly have seen a disproportionate incidence of COVID-19 among communities of color, and that there's a high percentage of cases in hotspot counties among people of color, and among all underrepresented racial and ethnic groups in these hotspot counties. The Latino community is the largest group that's living in these hotspot counties, with a disparity in cases identified within that population. And we also know that, unfortunately, data is something that is not in our favor. Oftentimes, there is a failure in capturing data to be able to give accurate pictures and accurate numbers of what is occurring in the community. And as all of us know, data drives policy, and certainly making sure that that data is available is very important, and that we're tracking this information to be able to formulate policies that impact the community at large. We also know that the Latino community is vulnerable to COVID-19 because of many factors, and what I'm going to dive into is really socioeconomic and physical environment factors. When we look at work and unemployment, we know that, as mentioned before by Dr. Sanchez, 5 out of 6 Latinos have to leave the house every single day to work and get paid. What that means is that Latinos are overexposed to COVID-19. And then when you look at the industries that they work in, we are the essential workers of America. We're over 1/4 of all grocery store workers. We're over 40% of meatpacking workers, and we're over 85% of all farm workers. We also work in other areas like waste management, cleaning and sanitation services, food delivery, as well as services like restaurants and hotels. We work in the health industry as administrators, as doctors, as nurses, as technicians, as janitors, and even as volunteers. When we look at unemployment, we know that unemployment is hitting the Latino community, again, because of the industries that we work in. And what we've seen is a range of 14% of unemployment. And we actually think that this is an underestimate, especially for Latinos who may be undocumented. In terms of housing, what we're seeing is that in addition to the work circumstancing, living conditions may also increase exposure to COVID-19 among the Latino community. In fact, 25% of Latino live in multi-generational household, and that's, compared to 15% of non-Latino white households. And again, this makes it really challenging when you have a multi-generational home and you cannot isolate yourself. We particularly see this in multi-generational homes that have that live in small quarters and are not therefore able to isolate if one of the members is impacted by COVID-19. By far, one of the issues that we saw at the very front of this pandemic is the issue of food insecurity. And just to give you a sense, LULAC was able to do a toolkit called Ayuda en Español, or Help in Spanish. And we got a lot of different influencers to help us uplift this. And one of the questions that we were getting from the community is, what is a food bank? And so in even thinking of the safety net programs that exist, there is still so much work that needs to get done in terms of making sure that the community is aware of these programs and the different efforts that are happening on the ground. I also want to paint the really stark reality that our community is facing at this very moment. And the different outreach that we have been doing, and we're doing massive hunger relief projects across multiple cities and counties in the US. And one of those volunteer efforts, what we found out from different families is that Latino families right now are having to decide if they purchase bread, butter, beans, or tortillas, frijoles, and oil versus laundry detergent. We're talking about $10, but so many of them are facing financial insecurity that even these basic staple items, they have to decide what they're going to purchase and what is a priority. And so I do want to make sure that we understand the stark reality that today, September 16, many families, Latino families across America, are facing. I would also add the issue of transportation. And we saw COVID-19 take off. Many of the public transportation methods in areas were shut down, which meant that many of our community who relied on public transportation did not have a way to be able to get to and from work. I think also equally important to note is that we saw that many in our community who did not have access to a vehicle were struggling to be able to do some of the basic things like going grocery shopping or going to a doctor, to a clinic, or being able to go to a pharmacy to pick up a prescription. And so that is very important. I will also share that the issue of technology is one that's increasingly important, particularly because of what we're living through this global pandemic, where some of us are able to connect. But when we look at the Latino community, 1 in 3 Latinos don't have access to technology, nor Wi-Fi or broadband. And so that is so important to note, because even in looking at solutions like telehealth medicine, it's important that we understand that we have to be able to meet the community where they are, and that we have a lot of work to do holistically in making sure that we're stopping the gap, even the technology gap. And again, this is an issue that's really important, because as we're looking at education, we know that the education gap is only going to continue to expand if our children, 1 in 3 children, don't have access to technology and to broadband. I also want to mention the factor of the environment, and this was brought up before, both by Dr. Brooks and Dr. Sanchez. And what we're seeing right now, especially amidst the wildfires, so it's not enough that we already had these massive disparities and now living through a global pandemic, and now we're seeing natural disasters occur. But what we're seeing in Oregon, Washington, and California is that some of our community members, particularly in our farm workers, are being forced to work even when the air quality is at a level that is highly dangerous to them. And this is something that's so important to address. We actually will be connecting with the governors of these states to make sure that there are no Department of Labor violations and that our communities are protected. But we talk about the issue of asthma and the importance of air quality and how this disproportionately, again, impacts communities of color. And so I did want to put, that flag in that, not only are we living through a global pandemic, we're also experiencing natural disasters, which are impacting our community. And particularly with the wildfires, we're seeing a displacement of entire communities occurring across the West. I did want to mention access to healthcare, and I'm only going to briefly touch on this because I do think that Dr. Sanchez and Dr. Brooks did a wonderful job in describing this as the experts that they are. But one issue that often comes up is the issue of language. And right on the onset of COVID-19, LULAC reached out to the CDC, this was in early March, to ask for information in Spanish around COVID-19. And the response from the CDC was, we don't have it and we don't know when we're going to have it. And so as a nonprofit organization, LULAC immediately stepped in to develop the information in Spanish to be able to put it out to our community. This is a real barrier that oftentimes impedes efforts to combat the spread of this virus in the Latino community. Something else to note, and we've seen this over and over again, not only at the local level, but even in statewide efforts through governor's offices, where information is translated, sometimes through Google Translation, and when you read it, it's filled with massive errors. And so it's not digestible and the community is not able to receive this information. It's so important that in any solutions that we form, that there be budgets allocated to translation services and to outreach so that this information does not live on a website, but it actually reaches the community it's intended to reach. I will also tell you that the issue of legal status is a huge one. And as all of you know, individuals who lack legal status are not eligible for federal relief and have not been included. In fact, even children and spouses who are U.S. citizens and mixed status families have been excluded from care relief packages at the federal level. And I hope that this is something that we can fix as we move forward, as this directly impacts U.S. citizen-born children and U.S. citizen spouses. Lastly, the access to healthcare issue is one that has been a long-standing issue for us. Latinos are the population segment without health coverage. In the United States, we are the largest population, and this, again, really unfortunately impacts us in being able to access tests and also healthcare. And again, to tie this back around with legal status, because of the public charge rule, and although the public charge rule was rolled back, the community is not informed that there was a rollback under COVID-19 of the public charge rule. So what we're hearing directly from the community is that they're scared to even step into a clinic because the perception is that the clinic is part of the federal government. Same thing with the hospitals. And that's so important that we are able to communicate these nuances to the community and that they understand the infrastructure that exists in the US. Right now, what we're seeing as a really great partner is actually the faith community, because there's that clear separation that churches do not belong to the federal government or are tied to the government. And so as we look at solutions, it's so important that we think of how we're reaching the community and who the best communicators are. As an organizer, I couldn't leave you without thinking of next steps and also just highlighting best practices. You know, in terms of best practices, it's always so important that the community be taken into account as part of the solution, and that we as practitioners and even policymakers meet the community where they are. In the end, they do hold a lot of the solutions, and we have to work hand in hand with them to make sure that whatever is proposed forward, that they actually have a voice and are stakeholders. There's this new saying, nothing about us without us. And I think as in America that is in 2020, as we think of Black Lives Matter and supporting our African-American community, that we are cognizant that we must have these diverse voices at the table to formulate these policies and solutions. And again, data, so important that as we look at different pieces of legislation that we include, ensuring that we track data so that we're able to formulate programs and policies that better impact our community. And of course, asking to please support HR 6561, Representative Barragán's bill, Improving Social Determinants of Health Act, as well as his companion bill S4440 in the Senate. And with that, Former Representative Christensen, I will turn it over to you. Gracias.
Okay, so good afternoon again. Gracias, Ms. Benavidez, for your presentation. Our last speaker is Mr. Patrick G., an AKF patient ambassador and kidney transplant recipient. Mr. G is a passionate advocate for for people with kidney disease and wants to be a beacon of hope to them in their fight against this terrible disease. Mr. G will share his boots on the ground view of the impact of health disparities on people of color with kidney disease. Mr. G.
Thank you, Dr. Christensen. And I also want to thank AKF for this opportunity to be able to share and to be on this esteemed panel. For myself, I am 3 years into a kidney transplant. I spent previous 4 years on peritoneal dialysis. One of the things that I see as a deterrent is that I wasn't diagnosed with kidney disease until I was at stage 4. There was no pre-diabetes information, no pre-kidney disease information. So you have a lot of people, especially as an African-American representing well over in the millions of people living with kidney disease, and a population of 13%, yet and still we represent 35% of those affected by kidney disease. And that doesn't even include people that are literally walking around undetected. When it comes to kidney disease and the comorbidities going with it, nobody told me that diabetes was the #1 leading cause, nor did they tell me that hypertension was #2. Also in that realm, we're looking at folks with obesity, looking at people with cardiovascular disease. So in undeserved, undervalued, disenfranchised communities, there is no educational materials being circulated. It's kind of like everybody tends to fall into these things. In these particular communities, everybody wants to live healthy, but how can you live healthy when you aren't given any opportunities to do so? When you talk about food deserts, or you talk about more dialysis centers being in those communities than actual grocery stores, banks, or even modes of transportation. I know for myself, everything was fine with me as I overcame my kidney transplant journey, which was very interesting. When I woke up from my kidney transplant on April the 21st, 2017, my kidney did not. So after going through 4 different surgeries, one to remove a blood clot, one to overcome internal bleeding, and another to create a laparoscopic peritoneal window for me to drain in, and spending 33 days of being hospitalized, my kidney didn't start working until the 47th day. So in my mind, if I would have been diagnosed earlier, maybe I wouldn't have had to even have been on dialysis or need a kidney transplant. And who would have thought, waking up in the year 2020, and now I have to deal with an invisible virus. So, you know, in March of this year, I'm COVID positive. And because I found out that a member of my church was positive, and me being immunocompromised, I figured since I'm in the at-risk population, I would get tested quicker. It took me 4 attempts to get tested. And when I did, even though my symptoms were mild starting out, as a transplant recipient, there was only one particular medication at that particular time for me to be prescribed to get, to kind of manage my COVID. That particular medication led me to have more severe side effects from COVID, which led me to being hospitalized for further testing, and now has led me to be dealing with post-infection fatigue syndrome, even close to 6 months after testing positive and now being negative. So when I go out into the community and have conversations with people that are on dialysis, those that are post-transplant, one of the things that I really feel confident about is going out there sharing the supportive resources that the American Kidney Fund has. The American Kidney Fund has really been there for patients to help them to better manage their bills financially with the support that they receive while they're on dialysis, and even those that are on that have received a kidney transplant. Now that we're in hurricane season, AKF also has a disaster relief fund that are also helping folks in this particular area to be able to manage themselves through natural causes. And one of the things that I'm so glad of is the COVID relief that they've been able to give to people in the kidney community that's been impacted by COVID. So when you listen to everything that everybody has said today, when it comes around to social determinants, being a person of African descent, now living in the age of wearing a mask, in the midst of people that feel that if they don't wear a mask, is in violation of their human rights. So now what a lot of people don't see behind the mask is kidney patients that are more at risk than anybody else in this community, living under mental duress, anxiety, fear, trepidation, each and every day having to make life decisions just whether they're going to go outside and try to regain some sense of normalcy in this world. So again, I just want to applaud AKF for everything that they've been doing. Thank you for allowing me to be able to share, and I look forward to further interaction with this panel.
Thank you so very much, Patrick. We are delighted that you were able to join the panel. And I want to thank everyone for just a tremendously rich discussion on the background, the incidents, and what this means on the ground for people who are dealing with not only kidney disease, but with these other diseases, chronic diseases, and now with COVID. Thank you so much, former Congresswoman Christensen, for your participation and for guiding this panel and for your contribution not only today, but over the years. The American Kidney Fund is grateful to everyone who has contributed, all of the organizations who stepped forward, and we know that working together, we have to address these issues. I saw some questions come up, and yes, this has been recorded. The information on how to get the recording will be on our website, and where we have contact information, we will also send out the links. So thank you so much. I'm going to allow you to say goodbye, Dr. Christensen. I know you're still on there before we close out.
Yes, thank you so much, LaVarne, and thank you to AKF for really putting this on. I know normally we'd be up on the hill doing this, but this way we're really able to reach many more people, actually, and so we're really grateful. And to the panelists, thank you for the information that you shared. We've gotten questions, and the questions have all been, when can I get this video? They want to show it to social workers, they want to show it to other individuals, and they want to just review it for themselves. So it's been very informative, and I thank you all very much.